everybody. This is Sharon Anderson, president of Leiomyosarcoma Support and Direct Research, or LMSDR. And I'm very pleased to have Dr. Matt Anderson with us today. Dr. Matt is an oncologist in gynecological oncology. Yes, Matt?
Actually, a gynecological oncologist.
Gynecological oncology at University of Southern Florida. And he also is a researcher. So I'm going to let him introduce himself more, and he has a PowerPoint show for us on HIPEC and uterine LMS. Take it away, Matt.
Good afternoon, everybody. Thank you, Susie and Sharon, for the invitation to speak to you guys today. As Sharon mentions, I'm actually, my background is that I'm a gynecological oncologist. I'm different, a little bit different than the vast majority of gynecological oncologists, in that I actually have a science background. I have a PhD in physics, biophysics. And I really went into gynecological oncology with the goal of doing a lot of translational research, which is where I've spent most of my life for the past 20 years plus in the lab. One of those interests recently has evolved to incorporate or focus on local regional treatments for gynecologic cancer, namely HIPEC. We here, about 4 or 5 years ago, I used to be the chief of gynecological oncology at Baylor in Houston, and I was recruited here to the University of South Florida to join one of my mentors for when I was a medical student at Yale, who left Yale to come down here to join the dean, who was also an OBGYN. Anyway, lots of small world networking type stuff. But the reason why I was interested in coming here is that I had been very interested in heated intraperitoneal chemotherapy for a number of years. And I was really having a hard time convincing my gynecological oncology colleagues at Baylor to join me in these endeavors. There's a lot of emerging evidence to suggest that HIPEC can be a very valuable therapeutic modality for peritoneal surface malignancies. Although, again, it's a little bit more entailed. It's not necessarily a simple or straightforward thing. So Tom has really been one of the kind of pioneers for HIPEC for ovarian cancer here in the United States. So I was very interested in joining him here because I believe that this strategy offers some very unique approaches and opportunities for treating things like ovarian cancer. And I think one of the questions that naturally arises is, can you apply this for other types of malignancies? And if so, under what circumstances? And how do you make that really work for people, right? We'll talk a little bit about today. What I thought we could do today is just discuss the technical aspects of HIPEC. So what is it? How do you do it? Okay. And why is this actually even an attractive strategy for treating any cancer? We can talk about some specific insight into the potential benefits about whether or not HIPEC is useful for treating leiomyosarcoma or other sarcomas, and what clinical data exists or doesn't in this case. Lastly, just on a little bit of a kind of more of a whim, explore some potential links between HIPEC and immunotherapy, which make it very interesting as well. And there's some interesting historical history behind HIPEC and cancer care that again supports or makes this an attractive strategy. And I'll introduce you guys to that kind of history a little bit, and why we're currently thinking or how we're thinking about moving HIPEC forward here at Tampa General. So with that said, what is heated intraperitoneal chemotherapy? This is most easily conceived as a system or strategy for delivering solutions of heated chemotherapy to the peritoneal cavity with the goal of better eradicating cancers that are lining the peritoneal surfaces inside the abdomen. For people who are not aware, inside your abdomen is essentially a hollow cavity lined by a specialized surface epithelium known as the peritoneum that essentially secretes small amounts of fluid throughout the day that lubricate and allow your intestines to move around within the peritoneal cavity. For women, your uterus, your fallopian tubes, and your ovaries live within the peritoneal cavity, which means that so when women ovulate, for example, the oocyte is shed into the peritoneal cavity, into that peritoneal fluid, where it is then swept up into the fallopian tube and down into the uterus. Fertilization occurs typically somewhere in the fallopian tube or down in the uterus. Occasionally, you can have like an erroneous fertilization that lands inside the peritoneal cavity, which actually provides a somewhat supportive environment for the growth of pregnancies, interestingly. And that fluid tends to be very nutrient rich. It's essentially a derivative of serum. And other organs that live inside your peritoneal cavity, the liver, your spleen, surfaces of the stomach, okay, your appendix, which is, part of coming off the large colon. And then there are other organs such as the pancreas, okay, which are retroperitoneal, which means they are inside your back, but out external to that peritoneal surface. The concept of intraperitoneal chemotherapy, heated intraperitoneal chemotherapy, was really first pioneered by an American surgeon by the name of Paul Sugarbaker, who's still practicing at the National Medical Center in Washington, D.C. To date, he first trialed HIPEC as a strategy for the treatment of cancer back in the 1980s, and since that time has published almost 780 manuscripts on this topic, examining the potential utility of HIPEC against a whole range of diseases. In addition, Dr. Sugarbaker has been a very prominent advocate for surgically aggressive debulkings of cancers. So I can share with you guys, when I was in medical school, my grandmother actually was diagnosed with uterine leiomyosarcoma, and we brought her to Dr. Sugarbaker because, by the time she was diagnosed, she had metastatic disease. The local surgeons where she was living here in Florida just basically shrugged. And so I had asked around some of my mentors at Yale, and they all pointed to Dr. Sugarbaker. So we basically brought my grandmother up to see Dr. Sugarbaker here in Washington for an aggressive surgical debulking, actually, which I think ultimately benefited her. Now, having said all that, she did not undergo HIPEC, although I will tell you that this is an impressive individual that I met not only in that context, but elsewhere. And he's focused his career on trying to figure out how to leverage this system to improve outcomes. So what is HIPEC really about? Well, it focuses and relies on two things that are clinically important, okay? The first is that this is a system for delivering chemotherapy to that peritoneal cavity, right? The peritoneal cavity is interesting. It has a natural circulation. So there are ways that this peritoneal fluid is secreted, but it's also taken up, okay, and removed from the peritoneum, okay? It has an immune monitoring system, okay? If you just look at healthy peritoneal fluid, it's full of monocytes, macrophages, other types of fluid, or lymphocytes. In part, it is exposed to things that are secreted from the omentum, which you can think of as sort of a fatty curtain that hangs off the transverse colon that really just consists of fat cells, blood vessels, immune cells of different flavors, okay? And that sort of acts as a surveillance device. And the peritoneal lining itself is just a thin little layer of cells that don't necessarily have a lot of specialized activity. They don't form what we would consider to be a secretory epithelium, say like the lining on the in-surface of your stomach, or the lining of on the inside of a woman's uterus, for example, that are designed specifically to secrete fluids and proteins to support specific biologic activities, such as digesting your food. This is just a little simple cuboidal epithelium that has its own distinct metabolism and defines its own unique sort of immune milieu, okay? Interestingly enough, when I was a fellow at MD Anderson, there was a guy there who, one of the faculty members, was very interested in considering the peritoneum as its own sort of discrete organ. And because there's very little that's understood about the biology of this peritoneum, how are immune responses regulated within the peritoneal cavity, for example, right? We know that omentectomy, when a woman has ovarian cancer, removing that omentum improves outcomes, and that's actually, in fact, the most common site of metastasis, reflecting a very unique biology that's relevant to ovarian cancer. For sarcomas, not so much. But interestingly enough, ovarian, other types of carcinomas that metastasize within the peritoneal cavity, gastric, hepatobiliary, cholangiocarcinomas, for example, pancreatic cancers, colon cancers, oftentimes will land and grow throughout the peritoneal cavity on different organs, and then secrete fluid, sort of like moss growing on a rock that's leaking water. Okay, and that fluid can accumulate because not only do these cancer cells clog up that normal ultrafiltration system, but they also bring with them abnormal blood vessels that really amp up the amount of fluid or serum that's leaking out into the belly. So back in the 1960s, oncologists began to explore placing chemotherapy directly into the peritoneal cavity via needles, okay, or catheters, to try to kill off the surface cells, kill off those cancer cells that are making and leaking out this and generating fluid and generating ascites that makes patients very uncomfortable, makes people very difficult for people to eat. And in the course of exploring how this intraperitoneal chemotherapy can be used, they found that there are certain drugs that are very large and that are not particularly water soluble, such as cisplatin, okay, that are cleared very slowly from the peritoneal cavity. Not a lot of these medications make it into the bloodstream. Okay, and this is in contrast to other things like metabolites, okay, methotrexate, for example, which is very quickly absorbed into your system. Okay, and so there are a lot of their efforts focused on using these larger drugs, okay, with the goal of amping up their concentrations very high to try to locally burn out that cancer and control ascites. Okay, they weren't necessarily looking for a cure, but they were definitely looking to try to at least palliate symptoms. Okay, and so that's the first sort of concept that from which HIPEC has grown. The second concept is the use of hyperthermia, okay, a very mild temperature, and to treat cancer cells. There is robust evidence to show that malignant cells can be destructively destroyed by raising their ambient temperature somewhere between 41 and 43 degrees Celsius. Okay, so and if you think of, I don't know if you guys have ever heard of the term heat shock proteins, but all of the cells in our body have mechanisms to protect us from heat, okay, that protect the genome, that protect damage from heat to chromosomes, and to protect the denaturing that occurs. What heat does when you fry an egg, for example, is to denature and cross-link proteins, okay, and it not only changes or eliminates their function, but it conceivably creates neoantigens, proteins that your body will not normally have been exposed to that could conceivably provoke an immune response, okay? And in addition, there are physiologic impacts of exposing a tumor, okay, or like a metastasis, like a chunk of tumor, to heat, okay? And there's also very good data to show that when you explore or expose a tumor metastasis to heat somewhere between 41 and 43 degrees, the microcirculation in that tumor slows and will not often frequently even completely stop in response to that heat. And in turn, that starves the tumor implant of oxygen, forces the tumor to kind of shift its metabolism that generates the secretion, a lot of lactic acid, which is then secreted to create a very acidic microenvironment. And this also contributes to the preferential death for malignant cells that are much more sensitive to this lactic acidosis than the average healthy cell that we might want to put into culture, or even if your body, if we expose it to mild heat. And so combining those two concepts, this is Dr. Sugarbaker's advance, was to rely on using high molecular weight molecules that are heat stable, low water solubility, that typically remain within the peritoneal cavity and can be delivered to patients at very high concentrations, up to as much 30-fold excess over what otherwise might be possible if we were to give those drugs intravenously. And the drugs that are frequently used in combination or frequently used clinically for HIPEC these days, cisplatin, mitomycin C, and doxorubicin, which is probably familiar to many people on the phone who have been involved in the sarcoma program or involved with sarcoma care, because that's frequently used to treat sarcomas, okay? One of the other things over the years that's really become apparent is that the degree of surgical debulking is critical for achieving success with HIPEC. If you look across the experience with HIPEC over the last 40 years, over not just Dr. Sugarbaker, but many other clinicians, both here in the United States, Europe, and elsewhere, looking at HIPEC, it's very clear that it's critically important to get that tumor out, okay, the bulky tumor out, because heat only penetrates so far, right? Okay, and so just creating a little burn or a surface char on a tumor isn't going to be enough, probably, to impact clinical outcomes. And in fact, our clinical experience with using HIPEC to treat people who still have bulky disease that's been left inside their peritoneum would indicate that that's very much, in fact, the case. Okay, so in general, but this system has become attractive and is attracting increasing amounts of attention for a number of things. One, okay, other benefits of HIPEC include the fact that you can use this mild degree of heat to improve drug absorption directly into cancer cells. That combining, it's essentially like combination chemotherapy. You use a single agent chemo, but combining it with heat as a combination treatment that renders those cells in turn more sensitive to cisplatin. Mild heat makes cisplatin much more effective at doing its job at damaging DNA in chromosomes. You can amp up the concentration of the chemotherapy, as I mentioned, up to as much as 30-fold greater than what's otherwise possible by an IV route. And there are many cancers where dose of intensification has been shown to work, but you're really capped by what patients can tolerate, okay, without making them unnecessarily sick in terms of your ability to use that medication as a cancer treatment. And perhaps one of the best things about HIPEC is that by delivering these treatments within the peritoneal cavity, using drugs that can't escape very well, we're really minimizing systemic exposure for patients to chemotherapy that can create nasty side effects: nausea, renal failure, hair loss, all kinds of side effects that no one really wants, right? And so it's a very attractive strategy, and become an increasing interest among oncologists as a strategy for treating surface malignancies or cancers that have metastasized within the peritoneal cavity under very specific circumstances. So this is what a typical HIPEC setup looks like in the operating room. This is actually not us. This is actually a picture of an operating room in Europe. You can see the patient here in the center. At the end, these are her feet, these two little arms down here. Those are her legs here. She's in the lithotomy position. So to the right of all the surgical personnel, you see the little kind of looks like a stand with a TV. That's actually a perfusion pump, okay, kind of like what you'd use for cardiac bypass, okay? And you can see these little lines here coming out of the machine, coming across the patient's belly. And what that machine is doing is it's literally pumping fluid, like you would for a heart bypass machine, through catheters that have been placed inside the peritoneal cavity that contain a solution of chemotherapy. And then there's a heating element contained in that machine that heats that fluid up. And you can control the patient's temperature, core temperature. So when you're doing this procedure, we do a couple things we do in an operating room. We actually do probably more HIPEC than any other site in any other hospital in the United States, except for maybe the Cleveland Clinic in Cleveland, because we have such a big ovarian cancer treatment program here at Tampa General. So with a bunch of things we do when we're administering HIPEC with the goal of keeping that patient safe. So for example, they'll have a thermometer that goes down to their esophagus, right, to monitor their core body temperature, right? Because if we overheat the patient, for example, that's actually when you start to see a lot of adverse side effects from that heating. So we monitor the patient's core temperature very carefully. The patient receives a lot of IV fluids with the goal of flushing that cool IV fluid through their kidneys and protecting and cooling off the kidneys, which are right there adjacent to the peritoneal cavity. The kidneys are a retroperitoneal organ, but they're right there underneath that peritoneal lining. And so that heat can transfer across the peritoneal lining and potentially cause renal failure. So we monitor it, the patient gets a lot of fluid. Typically, this patient's going to be lying on a cooling blanket because we're going to try to cool that patient's core. If the patient starts to warm up, their core, other parts of their body outside the peritoneal cavity start to warm up too fast, and we're not going to make it through the 90 minutes of the HIPEC perfusion, we use that cooling blanket underneath the patient, as well as ice. We literally we'll put ice bags along the side of the patient to try to cool off their core, so we can try to keep that treatment going, for example. Okay, so we monitor this patient very carefully while they're receiving this perfusion, and we're supported by a team of people to help get this accomplished. There are two ways in general to do this. At Tampa General, we use the technique on the right, which is called a closed technique. So we'll insert like what looks like a Y catheter that goes up over the two lobes of your liver that comes out through your incision. Okay, so the patient has a large abdominal incision, or we've used to debulk the ovarian cancer, for example. Catheter comes out. Okay, we use that as an inlet port, so the chemotherapy, a heated solution of chemotherapy comes in through that catheter, comes in up here at the top, and it lives over your liver. Okay, pushing this fluid throughout the abdomen, and then we drain it out with an outflow catheter, the tip of which lives deep in the patient's pelvis down by their rectum, with the goal of washing all the intestines and peritoneal surfaces with this heated solution of chemotherapy. Okay, there are people, we specifically use the closed technique for two reasons. The first is it allows us to make sure that we have treated all of the peritoneal surfaces that are relevant to a surface peritoneal surface malignancy. And so we want to make sure every surface of that peritoneum has been exposed to HIPEC, because if we've done an optimal debulking, which in our book translates to no visible tumor, our goal with that HIPEC is to try to eradicate any little cancer cells that maybe have landed and started to grow or metastasize to the peritoneal cavity, or might otherwise be floating around within the peritoneal cavity unattached. Okay, and so we want to make sure all those surfaces are adequately treated, number one. And number two, by closing the belly. So after we put those catheters back in, we just close the skin. We sew the skin back closed, so we can treat all those surfaces, and all those surfaces are exposed to the heated solution of peritoneum or chemotherapy. In contrast, there are other people who use what's called an open or Coliseum technique for HIPEC, where you leave that incision open, more like you're just putting clothes in an old school kind of tub with a washer, and then you sit there and it circulates and moves things around, literally like you're washing clothes. Okay, and you have a solution that comes in through the it's been heated, contains your chemotherapy, another outflow, and it's the relative balance between the rate at which the heated solution is coming in and the rate at which we're taking it out that determines, you always kind of monitor that on a consistent basis to keep that the range of this bath bathing the intestines and the peritoneal surfaces somewhere between ideally 42 and 43 degrees Celsius. Okay. And you can see a picture of someone actually undergoing this open or Coliseum technique here on the left in the bottom half of that figure. The other thing that we don't like about this is that it potentially exposes the whole OR to chemotherapy splashes, okay, which takes the whole, which may not sound, which isn't that big a deal. I mean, people have done studies at MD Anderson when I was a fellow. They just walked with little, like little wipes through MD Anderson, and they'd wipe the surface of the rack. You run your tray over in the cafeteria and doorknobs. And there's chemotherapy everywhere, right? Because lots of people getting it, everybody's sort of secreting it through their skin. It's just everywhere, right? Okay. But these types of big chemical spills in the operating room would essentially close down the whole operating room. Very easy to splash chemotherapy solution with an open technique like this, and that would take an OR out of commission at our hospital for a day or two while it's being decontaminated. And because our hospital is so busy and OR time is so precious, we can't really afford to have any type of a mistake like that, right? Okay, so we've avoided using this open or Coliseum technique, not only because we think it's like technically inferior in terms of treating the disease, but also because it leaves us vulnerable to accidents that we really cannot afford. Okay, now no data to show that one is better than the other. Okay, but it does introduce some questions that have not yet really been examined thoroughly in the field, right? There's never been sort of a head-to-head comparison of these two techniques. So again, this is a little schema showing how we're doing all these things, okay, because it's a little bit complex. as I mentioned, this is your hypothetical patient here on the right. There's an inflow port. We have temperature monitors. We monitor the temperature at the point it enters the patient's body, the actual heated solution, okay, which typically tends to be a little higher than 43. We have temperature monitors in the patient, okay, not only oral, but esophageal to measure their core temperature in the mediastinum. Some people also monitor temperature in the bladder, although that typically will end up reflecting the temperature inside. That's a reflection of the temperature inside the peritoneal cavity. We absolutely have a Foley catheter in because we're monitoring urine output very good. Our goal is to have a patient making a couple 200 to 300 milliliters of urine every hour, okay, as an index of making sure we're flushing enough cool IV fluid through their kidneys to help protect them. Okay, we monitor the consistency of the fluid coming out for bleeding, right? Because again, we're washing and irrigating all these surgical surfaces, things we've recently cauterized or tied off that have blood vessels in them. So we're monitoring the patient to make sure they're not having intraperitoneal bleeding. The catheter at the bottom over the pubis then drains fluid back out where it goes through this peristaltic pump with a heater unit, essentially a perfusion unit similar to what they use like in a intracardiac OR when you're on heart-lung bypass machine. It's literally very analogous, okay, to a heart-lung bypass, except we're not perfusing blood, we're perfusing saline with chemotherapy, okay? And for our approach, when we're treating cancer patients, we typically will do this with 90 minutes. The choice of the chemotherapy to some degree depends on what type of cancer we're treating, okay? So we actually end up doing a lot of HIPEC for colorectal patients at our institution. For those patients, the data supports the use of mitomycin C. For ovarian cancer, we typically use cisplatin. But again, these are not things that are well worked out, and many institutions do things slightly differently in terms of the exact choice of chemotherapy, duration of perfusion, the exact range of temperatures that they will accept that differ from institution to institution, even when the same type of cancer is being treated, okay? And that type of variation has in part made it very difficult to arrive at a consensus for any cancer, how these types of treatments should be performed. However, there is strong data to indicate that HIPEC can be used to improve outcomes, improve progression-free survival, decrease the incidence of metastases, and improve overall survival for patients with mesothelioma, intraperitoneal mesothelioma, low-grade appendiceal or mucinous colorectal cancers, epithelial ovarian cancers, and then more recently, some data to suggest that it may even play a role in improving outcomes for metastatic gastric cancer, which has opted to selectively metastasize within the peritoneal cavity. Okay, and we do quite a bit of this, particularly for ovarian cancer, because we actually are believers in this, have a lot of experience. We've had some really amazing outcomes for patients with this treatment, and are busy working on trying to figure out what is it about those patients or those patients' cancers that have rendered them particularly sensitive to using HIPEC as a strategy, and then how we can potentially combine HIPEC with other types of targeted agents to improve, like enhance very local or kind of local heating in the tumor microenvironment in combination with the systemic or intraperitoneal blanket treatment, or with the use of a combined agent, like a nanoparticle with an agent that specifically targets pathways that we think are potentially important for determining a vulnerability of an ovarian cancer, for example, to heat. So, having said that, another key element or aspect of this to keep in mind is that HIPEC is really the one thing all three of those cancers have in common is that they're all what are considered to be peritoneal surface malignancies. That is, they are cancers that grow along the linings of the inside of your belly. This is actually a picture of a patient of mine who agreed to allow me to use this picture with ovarian cancer metastases. You can see them here on the peritoneal lining. These little white dots here in the picture at the left are the actual implants of cancer. That's her stomach you're looking at there at the top. At the very, very top is her diaphragm. This is a laparoscopy with a camera through her belly button, and we're looking up towards her stomach. These little white dots are the cancer, and when you biopsy them and look at them under the microscope, this is what ovarian cancer, high-grade serous ovarian cancers look like under the microscope. These are the types of cancers. This is when someone says peritoneal surface malignancy, this is the pattern of metastasis that doctors and clinicians are talking about. Okay, it's also the type of cancer or pattern of metastasis that we believe is best treated by HIPEC. And HIPEC plays an important, valuable role because, yeah, you can argue that I can go in there and strip that peritoneal lining off the anterior abdominal wall without a whole lot of ill consequence, which we will do, okay? But when these metastases are growing over the surface, when you have small little implants of ovarian cancer, you sort of like spilled sand and it's landed and is firmly adherent to the walls of the intestine, much harder argument to make that we can remove all of someone's intestines to achieve that debulking, right? So we're using this particularly as a tool under those circumstances. We're seeing these small little microscopic implants, nothing larger than 1 millimeter or 2, to try to eradicate those cancer implants, and even the ones we can't see to manage ovarian cancer. Because again, if using ovarian cancer as an example, 80% of ovarian cancers respond to platinum-based chemotherapy and debulking surgery, but we know at the same time, 80% of those patients are destined to come back and have a recurrence, okay? And so we know that small volumes of metastatic disease can persist within the peritoneal cavity and keeps coming back, okay, to cause repeated problems, all right? And the kind of holy grail for gynecological oncologists over the years has been to figure out how best to eradicate that small volume disease. Here, I'm showing you there's at least one very robust prospective randomized trial that clearly compares equivalent groups of ovarian cancer patients who've achieved an optimal debulking to what we call an R0 debulking. And you can see here in red that the patients who've undergone HIPEC experience both an enhanced progression-free survival and improved overall survival, okay, using a HIPEC that relies on cisplatin chemotherapy being delivered intraperitoneally. Okay, now this is even without the addition of other things like PARP inhibitors that we have that could be used to treat ovarian cancer, particularly those that are homologous recombination deficient. And I mention that because there's also some debate about whether and how PARP inhibitors might be able to be used to treat other types of cancers, including possibly some sarcomas, okay? And interestingly enough, okay, HIPEC, there's very good data to show as part of the there's one paper, mostly relying on data in vitro in cultured cells and in animals, that for whatever reason, which is not well understood yet, that HIPEC actually downregulates BRCA2, okay, which is one of the genes that renders ovarian cancer so sensitive to a PARP inhibitor, okay? And so if that's in fact the case, okay, and then there's another paper that suggests, well, the benefits, and part of the reason, ironically, this paper has proven very controversial, okay, because there are all these other studies that have looked at using HIPEC in lots of different ways. Many of them haven't only looked at the efficacy for treating an optimally or an R0 debulk population. They use different concentrations of drug for different durations, lots of variation, right? And so this paper is also contradicted by several others that suggest that HIPEC doesn't work. Typically, those other papers that say it doesn't work have used HIPEC as a strategy to try to treat residual bulky disease, where I think the literature is very clear that it doesn't really help patients, okay? But if this is in fact the case, okay, if HIPEC downregulates BRCA, it's entirely possible that you could conceivably combine HIPEC as a treatment to render non-BRCA mutated patients sensitive to a PARP inhibitor, okay? And so for example, perhaps the money shot is not using cisplatin. Perhaps the money shot for improving ovarian cancer outcomes is to take patients who are not already BRCA sensitive, they're sensitized to PARP inhibitor by a BRCA mutation or a deficiency in homologous recombination, but use HIPEC as a strategy to render those cancers sensitive to PARP inhibitors and figure out how best to combine HIPEC with an oral administration of a PARP inhibitor, which typically has very few side effects. Okay. Ironically, published a paper several years back with Sandra Sulik that demonstrates that there are a proportion of leiomyosarcomas where BRCA is lost. Okay. And, okay, in general, okay, leiomyosarcomas are characterized by an overexpression of BRCA1 or BRCA2, okay, because that's the tumor trying to respond to the damage created by its genomic instability. And so conceivably, this is something that we could extend to consider using as a strategy for treating leiomyosarcoma, for example. Okay, and so we're very interested in trying to figure out and using this our experience with ovarian cancer about how to expand into and leverage and use HIPEC as a tool to treat other types of cancers. Okay. Because this study is controversial, there are at least 4 other studies I'm aware of, and now a 5th. The GOG Foundation, GOG Partners, which is the big clinical trial collaborative in gynecology and oncology, is now opening a study to evaluate HIPEC. It's being led by a guy named Oliver Zivanovic, who's at Memorial Sloan Kettering, actually, who I just spoke with a couple days about that trial. And he sent me an email about it. So I know there's at least 5 ongoing trials in different states of progress, looking at how to better define the circumstances in which HIPEC can be used to treat ovarian cancer. But that's not what you guys are interested in. You guys are interested in how do we treat sarcoma, right? Okay. And so, unfortunately, the literature on using sarcoma or using HIPEC to treat sarcoma is very limited. Okay. It's essentially limited to small series of case series, one-off case reports, retrospective data, with essentially no prospective trials that have yet been published in a meaningful fashion. Now, within that data, you can absolutely find evidence that would suggest or conclude manuscripts that conclude that HIPEC is potentially useful for treating sarcoma. And so this is an example of a report written up by, in fact, Paul Sugarbaker a couple of years back, okay, that demonstrates patients with diffuse peritoneal sarcomatosis that he debulked and then treated with HIPEC. And despite the fact that the average survival for a patient under those circumstances is probably a year or 2 at most, both of these 2 patients were alive and disease-free at 37 and 58 months following the combined procedure. And so he found this to be encouraging and very interesting. There's also at least 1 other retrospective multi-institutional study that looked at patients only with peritoneal sarcomatosis. I think our ability to use HIPEC to treat sarcomas is a little bit different than, say, our ability to treat, say, appendiceal carcinomas or ovarian cancers, which almost exclusively remain within the peritoneal cavity, because we know that sarcomas like to metastasize lymphatically and hematogenously. And so, even in early stage uterine leiomyosarcoma, I do a hysterectomy, no visible evidence of disease anywhere. That patient can have as much as a 50% chance of having a recurrence. And half the time that comes back in the pelvis, and half the time it comes back somewhere else, like the lungs, okay? And so, HIPEC is not going to necessarily be a useful strategy for treating a pulmonary parenchymal metastasis of your uterine leiomyosarcoma. And frequently, those things will occur in conjunction with one another. Right? There are subsets of uterine leiomyosarcoma patients that only experience a pulmonary metastasis. And again, there's very good data to show that if you resect those pulmonary metastases, that results in very prolonged. If you're someone who's had, say, a hysterectomy for an early stage, clinically early stage leiomyosarcoma, and 2 years later, you pop up with a nodular leiomyosarcoma in your lungs, the first thing that should happen for you is that should be resected, if at all possible, because if you can resect that metastasis, that's associated with 2 to 3 extra years of progression-free survival without any additional chemotherapy, right? So I wouldn't sacrifice that to perform a treatment that's only within the peritoneal cavity, right? And so the money shot probably for using HIPEC in sarcomas is, can we identify patients who are prone to only have intraperitoneal metastases, okay? And so do those patients exist? Yes, they're not all leiomyosarcoma patients or all sarcoma patients, okay? But there's some hints in the literature that under those circumstances, HIPEC might conceivably be useful. So this is a simple retrospective multi-institutional study where they pooled their patients. They identified a total of 36 patients who underwent 36 HIPEC procedures over the decade between 2005 and 2014. They'd all had, almost all had previous treatment, and one had only a primary treatment. 29 of these patients had leiomyosarcoma, 8 had an endometrial stromal sarcoma, 3 had an adenosarcoma, and 1 patient had some other type of a sarcoma not specified in the manuscript. 34 achieved complete cytoreduction. 19 of these patients recurred, okay? But this article concluded that HIPEC may be beneficial because when they looked at progression-free survival, okay, and overall survival for patients who underwent HIPEC, they felt that the progression-free survival for these patients was significantly longer, okay, favored HIPEC across this very small set of 34 patients. It was not years of extra survival, okay, but again, considering all these patients, all right, there was a hint of improvement in overall survival that approached statistical significance, okay? Again, study is limited by the very small numbers of patients that were enrolled, okay? So having said that, there's also a second study here, okay? This was a separate study, separate set of patients, retrospective evaluation, 26 patients, treated over an 11-year time frame at Mercy in Baltimore, okay? 5 of these patients had received chemotherapy or radiotherapy with no surgical intervention. 14 underwent surgery alone or in combination with, or received a combination of surgery and adjuvant systemic chemotherapy. And 7 of these patients received cytoreductive surgery combined with HIPEC. And when they went back and looked at the group of patients treated with HIPEC, that HIPEC did not result in any mortality, so the HIPEC didn't kill anybody, okay, which is great, a valuable question, okay. Only 1 patient had any type of a severe surgical complication. If you guys are interested, go and Google or start looking in the medical literature, you will see circumstances where people report very high complication rates, not only for upper abdominal debulkings, but even as much as a 30% mortality rate from aggressive upper abdominal oncologic debulkings, right? Where you have to resect part of the diaphragm, for example, okay? And there's a question in the literature that suggests that HIPEC may make that complication rate worse. Okay, that has not been our experience here at Tampa General, but in part, I think it's because we do some things in a very sequential order that are designed to protect things like anastomosis when you have to put bowel back together. But in this particular patient series, the median disease-free survival was 2.4 months for patients who were treated without surgery, just chemotherapy or radiotherapy, 5.3 months for patients who were treated with conventional surgery, and 11.3 months for patients who were treated with tumor reductive surgery plus HIPEC. The median overall survival was 35.9 months who were treated with conventional surgery alone, and 43.8 months for patients who were treated with the combination of tumor reductive surgery plus HIPEC. And this is probably the best evidence that we have that would indicate that HIPEC may have a favorable role in managing any type of a uterine sarcoma. Now, there is, interesting enough, there is some kind of ad hoc data for other types of sarcoma where HIPEC has gained a lot of attention. The most notable of these is this particular tumor known as a desmoplastic small round cell tumor, okay? These are aggressive tumors that typically present as an intra-abdominal sarcomatosis, okay? The disease typically confined within the peritoneal cavity in young boys, typically 4, 5, 6 years of age. They're characterized by a very specific chromal translocation, which I've shown you over here on the left. And in this particular, this is actually a retrospective case series that was put together by MD Anderson. You can see that these patients, oftentimes, many of their sites of metastases, many but not all patients are characterized by sites of metastases within the peritoneal cavity where it's conceivable that you could go in and manage that with an aggressive debulking. And when you back and look at their data, okay, you can see here in panel C, okay, patients who have had, and this is the money shot in this article, okay, patients who have had optimal or cytoreductive surgery, comparing those patients to patients who went optimal cytoreductive surgery plus HIPEC, had a statistically significant 2-month improvement in survival, implying that HIPEC had a role for those patients. Okay, and these are showing, and these other, for people who are interested, panel A, for example, is showing the benefit of an optimal cytoreductive surgery in this disease. B is showing, the response of chemotherapy, the improvements in survival rendered by chemotherapy. D is any type of radiotherapy, and E is whole abdominal radiotherapy. Okay, which I'm not a big fan of, mostly based on historical incidents that causes a lot of intraperitoneal complications, and people do not do well with that in general, but they did look at that. That's more of a historical treatment that had been used for a while, particularly at MD Anderson, elsewhere too, but that has really been largely discontinued. One of the elements in this manuscript was comparing how people did pre and post 2003, because patterns of care have shifted over time for this particular type of cancer. But the conclusion from this manuscript was really that these tumors, these round cell tumors sarcomas may actually benefit modestly from the use of HIPEC. And if you look in the medical literature, there have been several articles, and there's actually even, I believe, an ongoing clinical trial evaluating the role of HIPEC very specifically in this disease. Having said that, well, what if we look more broadly? Like, what does the data show? How do I put all that data? Because again, most of this is very small, a relatively limited number of studies, small numbers of patients. Okay, the most recent there actually have been meta-analyses performed in the literature. And this is the most recent of those, published by a group author in the European Surgical Oncology Journal by Wang and colleagues. They identified a total of 305 patients that have been treated across 43 different studies. They then weeded these out and kind of characterized them on the basis of how those studies were conducted, how the types of diseases that were included, and whittled those down to a total of 20 studies that were useful for addressing this question of whether or not HIPEC improves leiomyosarcoma or sarcoma outcomes in general. This is the data that they demonstrated. If you look across all sites, it does not look, if you look at patterns of local recurrence and distant recurrence, so panel A are the frequency of patients who experienced a local recurrence. Panel B, the middle set of figures, are the proportion of patients who experienced a distant recurrence. And then panel C is the proportion of patients who experienced a combination of local and distant recurrences. It doesn't look like that bar budges very much. And the way to most easily think about this, these box plots like this are really, you want to see that the line is the 95% confidence interval. So you really want to see the median with a 95% confidence interval not crossing or separate from the disease, the median for the whole population, right? And you can see here, there are these little hints where some studies would suggest that you're altering the pattern of local recurrences. In particular, these last two studies down here in the bottom two, one by Somariva in 2013, one by Sugarbaker in 2016, would suggest that HIPEC may have altered the pattern, reduced the incidence of local recurrences at the expense of more frequent distant recurrences. And the reason why I mention that is because we see a similar thing in ovarian cancer. So when we treat ovarian cancer with HIPEC, for some reason which we do not yet understand well, these patients are more likely to end up with recurrences in places where HIPEC is not typically, or ovarian cancers are not typically observed. Okay, and distant sites outside the peritoneal cavity. Now, there's only one study that suggests that, okay, but it's very telling, okay, and I mention this is because it may be that these two particular papers identify a pathway or a combination of treatments between optimal debulking, patient selection, use of chemotherapy agents, use of surgical technique that identifies a path forward or identifies a clinical signal by which we might consider pursuing how best to kind of evaluate or move forward with HIPEC for treating sarcoma. And so, but unfortunately, if you go back and look at overall survival, the overall survival, the use of HIPEC in a weighted analysis, the authors in this study went back and tried to weight and sort of handicap different studies by the various limitations that they perceived to be how those manuscripts have been put together scientifically. Across the whole groups, it does not look like, from a statistical perspective, that HIPEC improves either the progression-free or overall survival for patients. Although, interestingly enough, okay, there seems to be some hint, and interestingly, even though these findings were not statistically significant, the authors concluded, as you can see down here, that HIPEC may improve outcomes in a select group of peritoneal surface sarcomas, particularly leiomyosarcoma and liposarcoma. Now, I would caution you because, interestingly, they published this conclusion despite the fact that those were not statistically significant observations. Okay, so again, but okay, in their defense, okay, these are very small numbers of patients, and again, all of these manuscripts were done. Involved patient populations that were received care that varied significantly, not only from manuscript to manuscript, but from institution to institution, right? I mean, it's essentially comparing very mixed bags. You're not necessarily comparing, there's no good patient or manuscript or study that really has examined this question in a rigorous fashion, okay? Where you're comparing likes to likes. Ideally, it would be a patient with peritoneal sarcomatosis or a limited peritoneal recurrence of their leiomyosarcoma or liposarcoma who have only had an intraperitoneal recurrence, looking at patients for whom you can achieve an optimal or what's called an R0 surgical debulking with or without a HIPEC. And then the question would arise, what chemotherapy agent to use? Okay, there's really no insight on that. Ironically, even in this meta-analysis, the vast majority of patients were treated with cisplatin or other agents to which most sarcomas don't typically respond, okay, which is another limitation of literature, right? The HIPEC, they're applying HIPEC as we've thought about it for epithelial carcinomas that respond to things like cisplatin, okay? And so now, interestingly enough, even though that paper really had no statistically significant improvements in outcome that they could find that were associated with sarcoma, but they made this conclusion that leiomyosarcomas may benefit from the use of HIPEC. There actually has been a meta-analysis performed by a group at USC that looked at the 10 studies that had been published between 2004 and 2020. There have been a total of 8 case series covering 28 patients and 2 original articles covering 47 patients that have tried to evaluate whether or not HIPEC might benefit patients experiencing a recurrence specifically of their uterine leiomyosarcoma, okay? The vast majority of these patients were women with uterine leiomyosarcoma. Only 7 were women with non-uterine leiomyosarcoma. I mention that because I think there's pretty robust molecular evidence. We presented some of this at the SGO a number of years back through the TCGA that suggests that from a molecular perspective, uterine leiomyosarcomas actually have some distinct features from non-uterine leiomyosarcomas. The vast majority of these patients were people who were receiving treatment for recurrent disease. Perioperative mortality rates were low. Okay, so clearly we can perform this procedure safely for people. Postoperative complications occurred in about 20% of patients. At our institution, I can tell you we have much lower rates of postoperative complications than this. But again, even in this very limited case series of 10 patients, the vast majority of patients receive cisplatin, which largely doesn't have much activity against leiomyosarcoma. You're relying on the HIPEC to sensitize the sarcoma tissue to the ability of cisplatin to damage DNA. But maybe that's not the right route to really look at this, right? People have used melphalan, but which again, unclear to what degree that's really going to be helpful, but really haven't looked at other things such as the use of doxorubicin when we know that that can be combined with and used to administer HIPEC, okay? And we know that doxorubicin has activity against leiomyosarcoma. The overall survival in the 2 observational studies for people who went optimal cytoreductive surgery plus HIPEC ranged between 29.5 to 37 months. And the very limited ability, okay, to look at effectiveness comparing HIPEC to people, tumor reductive surgery plus HIPEC to a population of people who only went cytoreductive surgery. again, the statistical progression-free survival rates were much better in HIPEC treated patients, but again, the difference did not achieve statistical significance. Okay, and so again, disappointing results. But I would caution you that this data is tiny. These are tiny numbers of these patients have enrolled. These have really only enrolled very limited numbers of patients, tiny numbers of patients, and it would be very easy to miss the impact of an effective treatment simply because these studies undoubtedly lack statistical significance or the statistical power to detect the impact of a modest favorable impact or even unfavorable impact. So where do we go from here? Well, first of all, there are 3 current ongoing clinical trials looking at HIPEC, the utility of HIPEC in any type of sarcoma that are actively enrolling anywhere in the world. One of these, the bottom one, is being conducted in Singapore. There's actually one going on at Stanford. This top one here looks at uterine leiomyosarcoma. They're using gemcitabine gemcitabine and dacarbazine as the chemotherapy agents, okay, for treating sarcoma, which I think is a little better than using cisplatin. It was opened about 2 years ago. No results have been reported yet. Okay, their target enrollment is 25 subjects, and I have no insight into the I have no insight into how this study is actually proceeding. Actually, the other looks at the potential role of HIPEC in pediatric sarcomas, and that's also actively enrolling at the Mayo Clinic in Rochester. Again, no results have been published. I can't find anything in the literature that gives us any insight or a preliminary analysis that would suggest whether or not the strategy being evaluated in this clinical trial is of utility. Okay. One thing to keep in mind, however, so what's the way of coming down the future? Well, there actually is an ongoing national trial looking at what is called PIPEC, okay, or PIPC rather than HIPC, which is a laparoscopic approach for delivering tumor debulking combined with heated intraperitoneal chemotherapy, using those laparoscopic ports to pressurize and combine pressure plus heat plus chemotherapy to treat cancer. Okay, and so this study was started enrolling back in this particular study. It's a collaborative City of Hope, and I think a couple sites in Europe are actually enrolling into this. There has been at least one published manuscript or MELSA looking at a PIPEC for treating ovarian cancers, and no negative impacts on quality of life. And they saw at least the overall clinical response rates to PIPEC were somewhere in the range of 62 to 88%, which for ovarian cancer is pretty good. But not enough to convince me that it's improvable in survival. The current enrolling study is looking at, it's not open to sarcoma patients to the best of my knowledge. It's being led by a woman named Ton Dellinger, who's at City of Hope. And the problem with this study is that it includes patients who have residual disease, bulky residual disease. I can tell you just from having talked with some of the collaborators in that study that they are not seeing, for example, things like changes in patterns of gene expression in the residual disease that's left behind that has been exposed to the PIPEC. The concept was that perhaps by pressurizing this, using by keeping a closed abdomen and using only laparoscopic ports, that you could force more chemotherapy into the tumor to achieve better clinical outcomes. But that doesn't sound like unclear whether or not that's actually really working, right? But again, no published data for us to truly know. Okay. And again, we talked about, as we've gone on, okay, about ways in which, we might be able to think about alternate strategies to use HIPEC to treat or approach different types of cancers. One of the big questions, though, that no one's really asked is, does the chemotherapy that we're putting into HIPEC really matter? And to kind of, just as a historical thing, to kind of stimulate you to think a little bit about this, okay, is I was going to share the experience of a physician who's named William Coley, okay, who essentially was the first physician ever to use any type of immunotherapy to treat patients with cancer. Okay, and back in 1891, okay, surgery was really the only option that was available to treat cancer patients. Dr. Coley had been caring for a patient by the name of Bessie Dashiell, who was a good friend of John Rockefeller. Okay, patient expired under his care. was very frustrated by that. And so he'd been reading about some things, and he decided to use or to trigger inflammation in a patient with the goal of trying to see if he could use that to treat cancer. And so what he did was he had a patient who came to see him who had diffusely metastatic cancer, including one in his throat that prevented him from eating. So he was essentially had reached the end of the road, unfortunately. And what Coley did was to inoculate this patient with live bacteria and essentially induce sepsis, okay, an infection, okay, keeping in mind, okay, that this induces inflammation. Right. And ironically, for this patient, it worked. The patient's tumors resolved. The patient made a complete recovery and lived for another 26 years. Why? Because, okay, infection results in diffuse systemic inflammation. Okay. And interestingly enough, if you go back, and again, I know I keep mentioning ovarian cancer, but if you look at the ovarian cancer studies, okay, that we'll look at, there's a whole series of studies that look at the combination of intravenous and intraperitoneal chemotherapy, where they're trying to deliver without HIPEC, okay, to treat ovarian cancers. It's very interesting because that combination of intravenous and intraperitoneal chemotherapy, the study was done led by investigators at the University of Oklahoma. That was the most recent, or the most of these studies was done almost more than a decade ago, close to 12 years ago. And in that study, 12% of ovarian cancer patients treated, or not 12%, 25% of ovarian cancer patients treated with the combination of intravenous intraperitoneal chemotherapy have been alive without any evidence of disease recurrence, despite the fact that only about 25, the median disease-free interval for ovarian cancer, until the introduction of PARP inhibitors, is under 2 years. Okay, and so this study is very interesting to me because, first of all, it establishes that dose intensification in the intraperitoneal chemotherapy can benefit patients, right? The other thing is, and that benefit can be long-lasting, but the other thing nestled in that data is a subset of patients who had an intraperitoneal port placed, okay, but did not receive intraperitoneal chemotherapy. So in that study, the way in which you give intraperitoneal chemotherapy is you port what looks like a Metaport that would use to give chemo into a vein, but you basically install it so it empties into the peritoneal cavity, and you use that to administer the chemotherapy. So there is a subset of patients who had that catheter placed who, for whatever reason, did not go on to get the chemotherapy. And interestingly enough, okay, in not very well publicized subset analyses, placement of that catheter resulted in clinical benefit, which is interesting. Why is that? Yeah, but what you've done is place a foreign object in the peritoneal cavity that stimulates inflammation. And that by itself has been enough to benefit some subset of ovarian cancer patients. So could the same thing be true, right? I mean, I think this gets to the heart of, we are just at the infancy of knowing how to exploit the immune system to attack many different types of cancers, okay? And our suspicion, and part of the reason why we've been so interested in HIPEC here at Tampa General, has been that we believe that the HIPEC is one route by which we can modify and amp up immune responses to a variety of different intraperitoneal malignancies or metastases. And so I would just leave you with that thought, because, interestingly enough, Coley did go on to develop a mixture of bacteria for treating cancer patients, but it sort of got pushed to the side by the advent of radium and subsequent invention of chemotherapy. But again, I think some of science has come full circle in that, his work may have not just been limited to inducing inflammation. By administering a diet or treatments containing a mixture of bacteria, it raises other things that we know little about, like the role of the gut microbiome in determining, for example, HIPEC outcomes. One of the things we are clearly doing when we treat patients with HIPEC is warming the intestines, and undoubtedly we are having an impact on the gut microbiome, right? 95% of your stool volume is bacteria, okay? And so under those circumstances, are we altering the gut microbiome? And is that possibly involved in how HIPEC improves cancer outcomes for some patients? And so that's another thing we're interested in trying to study and learn a little bit more about, and is potentially relevant to how we may or may not be able to use this to treat sarcomas. So having said that, I think I've reached the end of my slides. Probably talked enough for you guys. Hopefully I didn't lose too many people, and this was helpful, but I thought I would give you guys a chance to ask questions.
Thank you for such a thorough and comprehensive presentation. I mean, I don't know what to say. I have a few questions here. First is, are there any side effects to HIPEC?
So, in our hands, we have so what we talked about, if you were coming to see me as a patient, what I would tell you is that HIPEC is essentially like a sunburn on the inside, right? Okay. I don't know if you guys have been outside, you got a good rip roaring sunburn, you feel sort of swollen and achy and sore. Okay. That is, I think, sort of what you can think of HIPEC as doing inside the peritoneal cavity. So how does that manifest itself? First, it slows the natural return of, anytime you make an incision in somebody's belly, everyone experiences a physiologic stress response where normal gut peristalsis stops. You have changes in the hormonal milieu, things that drive your sugars up, okay? Glucagon goes up, insulin goes down, okay? Stress response hormones go up, okay? You tend to third space fluid, okay? And then at some point after your laparotomy, your body decides it's no longer stressed, and that hormonal response resolves. People diuresis, they pee out all that fluid they've packed away. People not after a big surgery will complain about feeling puffy, and that's not a figment of the imagination, because their body's absorbing fluid and tucking it away in your tissues, okay? HIPEC tends to exacerbate that, okay? And so in our hands, when we're doing HIPEC here at Tampa General, typically we watch patients for the first night overnight in the intensive care unit. We monitor their bowel function very carefully. Many patients are able to get the NG, we keep everybody an NG tube in place. Probably for about 50% of patients, we'll keep them intubated and anesthetized overnight, particularly if it's been a long case, or if it looks like the patients, it looks like they're sort of tolerating the temperatures a little bit. Their temperatures were creeping up, or there's some patients you do HIPEC for, and they're like a rock, right? Okay. Other patients don't tolerate the procedure necessarily as well in terms of maintaining their intraoperative temperatures. And so if people are struggling with maintaining their intraoperative temperature, we're more likely just to leave them intubated, because again, these fluid shifts, one of the downsides of the fluid shifts is it can cause laryngeal swelling. And so we just leave them intubated overnight to give them a chance for that swelling to go down. Theoretically, it can cause injury to your kidneys. It can shock your liver. If you look in the literature, there are suggestions that if the HIPEC leaks across your diaphragm around your lungs, that's going to cause a lot of problems. I can tell you, in our hands, we have not had that problem. And in fact, okay, ovarian cancer is very prone to leak across the diaphragm and cause pleural effusions. We sort of call this like lung peck, and it has been, people have even explored kind of an analogous HIPEC, a pleural HIPEC, as a tool to control pleural metastases, for example, right? Okay, but we have not seen a lot of pleural effusions, which people have. If you look in the literature, other cancers where HIPEC is used, they'll report rates of post-operative pleural effusions that require either drainage or placement of a pleural catheter. I would think in the last 4 years, I've only had about 2 patients that have required a pleural catheter, despite having performed hundreds of these procedures. We do not see a lot of liver abnormalities. Nobody loses their hair. I've not had any patients going to liver failure or renal failure or bump their creatinine to any significant degree. By and large, at our institution, 80% of patients go home post-op day 1. The next morning after your ovarian cancer debulking, we're able to send home because of how we manage the anesthesia, the surgical time, and because we are pretty serious about getting that surgery done. Despite very aggressive debulkings, we're able to send patients home, 80% of our ovarian cancer patients home the next day. For these patients, maybe they'll go home the second or third day, mainly because we slow down, okay? And so we may refeed them very slowly after that surgery. Pain may be an issue because, again, it's like having a sunburn on the inside. all of our HIPEC patients pre-op get a high epidural catheter. We use a regional catheter to induce, almost like having a spinal for a C-section, but up higher to control pain. We're able to get rid of that catheter typically by the second day post-op. And we have had plenty of experience with that catheter for whatever reason has not worked, but we are able to usually get very good pain relief post-operatively for patients without having a lot of side effects. And so we have not seen, and absolutely no one has died or come close or had any type of acute decompensation or multi-system organ failure, okay? So you will find some reports that mention these types of things following HIPEC. We do not see that, and we have not experienced it, and we have probably done more HIPEC than the vast majority of anyone else, of any hospital center in the United States, except for maybe the Cleveland Clinic. So we do not believe that these specific side effects are worrisome. We do both, and again, our experience ranges not only just for ovarian cancer, where we use cisplatin chemotherapy, but because the general surgeons here are not certified to do HIPEC, we the gynecology oncologists end up doing all the HIPEC for male patients, like colorectal cancer patients, right? So all the colorectal patients undergoing, or appendiceal carcinoma patients, men coming for a HIPEC from the VA, for example, get referred to see me. They get the referral to see the gynecologist, actually. Which has induced a little bit of humor for some of these patients, but we've not seen side effects with those patients either, right? So we have not seen many of the side effects that are reported in the literature, and the most common is just that it probably the return of bowel function is delayed by a couple days, and they may require, their pain medication needs maybe are higher than patients who do not undergo the procedure.
Great. Wow. We have a few questions in the chat box if you want to read those. Let's see.
Let's see.
Scrolling up here.
Yeah, okay, let me start at the top so I can just answer these. And okay, so we talked about the side effects. I think the best person who'd be a candidate for HIPEC is someone with disease metastatic, whose metastases have remained within the peritoneal cavity. It could be there have been some case series where people have looked at retroperitoneal metastases. We will do it. You see similar things in ovarian cancer, for example. If you can get in there and get that tumor out and resected, then it's within the peritoneal cavity, even if it means you're taking out a portion of bowel, you're taking out your spleen, or you're doing a retroperitoneal dissection to get all that tumor out. If you leave behind a surface that's visibly clear of tumor and fluid and HIPEC fluid can get to it within the peritoneal cavity, and there are no sites of metastases outside the belly, okay, then I think then you are theoretically would be the best candidate for HIPEC. I do not perceive HIPEC as a strategy for treating distant metastases, pulmonary metastases, CNS metastases, extremity metastases that can occur with leiomyosarcoma. And I think that's why you don't hear more about this procedure. We don't do a lot of this for leiomyosarcoma patients because, again, a lot of our patients already have some other type of distant metastases that we don't perceive HIPEC to be a good treatment option for. Okay, we talked a little bit about the side effects, that would be, I think those are very manageable. It's certainly, in contrast, I mean, the NIH for many years has pushed combination intravenous intraperitoneal chemotherapy as the standard of care, trying to establish that as a standard of care for ovarian cancer. I will tell you that half the patients in that trial, the trial I mentioned to you, where there were people who received that, there were like 25% were 10-year survivors. Half the people in that trial, it's an interesting trial because there was a huge survival benefit observed on what's called an intent to treat analysis, right? So people who, they were randomized for treatment, they were like, forget you, okay? And something like half the people in the treatment arm, okay, unenrolled themselves and went back to standard of care because the side effects were so awful. Pain, cramping, it's multiple days in the hospital. We have you like rolling on your side, moving around in bed, okay, to like get that chemotherapy to shift around. The catheter gets clogged, all kinds of stuff happens, okay? And a huge proportion of the patients on the intent to treat arm failed to complete more than one cycle of combination IV-IP chemo, but still observed a benefit. Okay, when you look across all the patients, you still observed a benefit. Okay, and and the reason the dropout rate was so high was because the side effects were so awful. Okay, I have never had a patient wake up and tell me, and I talk to my patients a lot, okay, and hopefully I'd like to think they feel free to tell me if it was something that was miserable, and they frequently do. I have, but I've never had a patient tell me that they would never do that again. Okay, and so I think that is important, right? Because there are things we do for patients, and they're like, "That was awful. I'm never doing that ever again." And I listen to that, okay, but I've never heard that from a patient about their HIPEC. Okay, and so I think the side effects are manageable. Okay, I do not know if Coley's mixture is available. There are multiple trials. We're actually opening up a trial here at Tampa General looking at lipid supplements to treat ovarian cancer. There are people who are very interesting, relevant to sarcomas. There's a study that we're opening up here. It's a company from Glasgow, Scotland, that has a nutritional supplements. It turns out that if you starve patients of glycine and serine in their diet, okay, that you can sensitize them to AKT inhibitors, okay, which have been studied in sarcoma. So activation of AKT signaling pathways is a feature of sarcoma, particularly leiomyosarcoma, okay? And so this investigator, he really looked at it in colorectal and pancreas cancer, okay? In fact, he was just here to give grand rounds a couple of days ago, and I went to his talk, and I'm sitting there the entire time thinking, wow, this could really be useful in sarcoma, right? Because, AKT, these pathways are very strongly activated in leiomyosarcoma, for example. And he has very robust data. PI3 kinase, AKT pathway signaling is really part of the reason why those inhibitors don't work better than they do, is because you are driving insulin and your diet is driving metabolic bypass of the inhibitor, okay? And so this guy's concept is to starve patients of glycine and serine, because he specifically believes that this diet sensitizes colorectal and pancreatic cancers to AKT inhibitors and radiotherapy, okay? And so there are other nutritional supplements being studied if people are interested in that, and I would encourage you to look around because these things are probably very real, and I think are gaining in prevalence, and attention. It's an area that's gaining a lot of accelerated interest. This question here about morcelated, okay, about morcellation. Yes, I probably would offer it to patients, okay? There is a case series, actually there has been some data published on this, a very small case series of patients who had laparoscopic morcellation of a uterine leiomyosarcoma that was then followed over the very short acute term with HIPEC, okay? And to me, this seems like it would be potentially an ideal circumstance where you could offer patients HIPEC, right? I think that's a fantastic trial, okay? And in fact, I have a graduate student wanting to, or a resident wanting to do something, and I was thinking about having that person write up exactly this clinical trial, okay? The problem is enrollment, right? Because hopefully, I would pray that there's not a lot of that going on. Although I will tell you, we've had several uteri here in Florida that have been sent to me recently where someone did exactly that. Okay, and the minimally invasive subspecialty of gynecology is always trying to push this. Okay, and so hopefully that doesn't happen very much anymore. Although I know that's not, it's not a zero rate of occurrence. But, so always the question is, could you enroll enough patients in a trial like that? But I think this could be very useful. And there has been at least one exact manuscript published by Sugarbaker on exactly this topic. I think it was like 6 patients he looked at, and all of them had good long-term survival.
Matt,
so,
I have a question. Do you have to be in a trial to be able to get HIPEC?
No, if you can find a surgeon to do it for you.
Okay.
No, I mean, I think it's better if you're in a trial, but if you can convince, there are a lot of centers, particularly gynecology and oncology centers, that are gearing up to offer HIPEC to ovarian cancer patients.
Okay.
But situation's a little different, right? There's robust prospective evidence that supports that. It's still hotly contested, right? Okay, but there is prospective evidence that very clearly indicates multiple studies that indicate a benefit, right? Unfortunately, there's no data to support that in leiomyosarcoma. And I think that, I think patient selection is going to be very important, right? In no fair exposing somebody to extra risk, under circumstances where they're unlikely to have a meaningful benefit. So if you've got a lot of distant metastases, I don't, maybe that's not the procedure for you. Okay. I think, and so, but I think that, Sharon, that circumstance that you mentioned, like morcellation, I mean, to me, that's like perfect, right? Because that's exactly what the problem is, right? Peritoneal spill of tumor cells that come back to haunt you and you can't get them all out, right? Okay.
Right.
Then the question is, well, what chemo do you use, right? Okay. Again, most people in the literature have used cisplatin. I don't think that's a great idea, right? And so I think, either mitomycin C, gemcitabine is, amenable to the use with HIPEC as well. And there are data support that, in addition. Taxol, not so much, okay, because that gets absorbed through the peritoneal lining. It's not large enough to stay within the peritoneal cavity selectively, like we talked about. But interestingly enough, adriamycin is, and I've never had I haven't looked into this well enough, honestly, but you don't see a lot of studies looking at adriamycin. I don't know if that's because somebody has looked at this already, and I haven't found that literature yet where a lot of side effects or something. But I don't see that used with HIPEC, even though I think the older literature has used that as we know that it stays selectively within the peritoneal cavity, right? So I think that's something, anyway, I think there's a lot of work that could be done in this area.
Okay.
Would someone who is pelvic surgery remove a mass be eligible? I mean, theoretically, yes. I think it depends on how long. The question is it worth a whole separate surgery? To make this work, you're going to end up with a pretty good sized incision, okay? And I think that for us in our practice, we tend to limit the use of HIPEC to windows of opportunity when we're already going to be in someone's belly. And I don't think that's a vote on the efficacy of the procedure, but I think there's really no data that I'm aware of that shows that you can have a surgery and then 3 months later come back and have a HIPEC, and that's going to actually help you, right? Okay. So again, we're sort of veering off into situations where unclear and lack of data. The chemo question is, again, unclear what's really going to work best. I would probably use either mitomycin C or gemcitabine for this, okay? And I probably would stay away from cisplatin because, again, I don't think cisplatin does a whole lot in treating leiomyosarcoma or sarcomas in general. And I would want to pick something that at least at baseline has some activity, right? Is this used if the metastases in the abdomen tested? Yeah, we use it as frontline, not in sarcoma so much, actually. Although, again, I think there are circumstances, it's not been used. There's no study to show, the other circumstance. The question is the other circumstance along the line of what Sharon asked, which is, well, what about patients who say had a laparoscopic cyst, you discover a leiomyosarcoma, no palpable lymph nodes, you don't get a lymph node debulking, you get a PET CT, it's all negative. Is it worth going back and getting a HIPEC? And I think the data on that's very unclear, right? There is no data for starters, okay? We have nothing to guide us. My enthusiasm for that is a little bit tempered by the fact that, the frequency which those patients may experience a recurrence is probably no greater than 50%. And then when you have a recurrence, probably 50% of those or more, probably closer to 2/3 of those patients are going to have a recurrence that includes or is limited to some type of a distant metastasis, okay? And so I think you've really narrowed, so if you kind of do the math, when I think about this, maybe we're limited to maybe 10 to 20% of those patients benefiting from HIPEC, conceivably. And then the question becomes, then that whole interval question arises, right? Okay, we have no data on that, okay? And then the chemotherapy question arises. And so we've not offered it to our patients here under those circumstances, mainly because we're just not certain if it really does anything yet, right? I think if it's conceivable, that's probably not something I would do outside the context of a clinical trial. But clearly, I think under circumstances where someone has already experienced a recurrence and they've sort of proven themselves as to the pattern of those recurrences. If someone comes back to me with an intra-abdominal recurrence of their leiomyosarcoma that's confined to the peritoneal cavity, and I think I can optimally resect it, would I consider that a HIPEC for that patient? Absolutely. Right. I think that's different, right? Okay, because I think there's a much greater likelihood that that subset of patients, those patients are going to benefit. Okay, I think that the others context this, an early stage 1, no evidence of metastases disease as a purely adjuvant therapy to decrease the incidence of metastases. I think we might be asking too many people to pay a price with no possibility of a benefit, right? So I don't think that's something that should be done. Personally, I just don't think that's something that should be done outside the context of a clinical trial. Let's see. I do not know who. Oh, Zivanovic. This guy Zivanovic. I don't know if he does this for leiomyosarcoma, and no data on treating leiomyosarcoma in the lungs. Okay. Typically, I would probably say, unless it was a pleural surface, I would probably not use HIPEC. Okay. Most pulmonary metastases of leiomyosarcoma tend to be parenchymal, although there are some that are pleural only. But again, if it's in the lungs, my first recommendation, and if the only metastasis is in the lungs, my first recommendation is wholeheartedly to have that thing resected, because there are multiple manuscripts, published data, peer-reviewed data, that indicate that resecting pulmonary metastases offers patients with leiomyosarcoma, or even any gynecologic sarcoma, years and years of disease-free benefit with no chemo. Okay, and so I don't think I would trade that, a proven benefit, for the theoretical benefit of HIPEC, right? And then if you're going to ask me, well, what if we resect it and then add HIPEC? Well, again, because so many patients benefit from this, and if you look at where those patients experience recurrence, a big chunk of those patients will then go on to have at least 60% of those patients will have an intraperitoneal recurrence. I'm not so sure that performing a pleural HIPEC is going to be a big benefit following an optimal resection, right? So again, I perceive the benefit of that to be potentially more limited. Let's see, other questions. Massachusetts question, yeah, Mass General, Memorial Sloan Kettering. I don't know the people at Mass General doing it. It may be the GI surgeons. The guys at Memorial Sloan Kettering, I know, actually. Why is it not more readily suggested? Well, again, very limited data. There's no conclusive prospective randomized trial to demonstrate a clear clinical benefit. Okay, and it sort of gets down to your philosophy as an oncologist, right? And so I think you would have to find someone potentially willing to think a little bit outside the box to assume that risk. I think that it is not. Many people end up practicing according to NCCN guidelines, and there is no NCCN guideline that recommends the use of HIPEC for the treatment of sarcoma. Okay, so if I'm following the rules as an oncologist and strictly practicing solely by NCCN guidelines, then you're not going to find that in an NCCN guideline. Okay, and that's relevant because oftentimes insurance companies will deny a procedure if we're not conforming, as an oncologist, we're not conforming to those guidelines. So there may be many reasons why that person doesn't do it. Many surgeons, oncologic surgeons, have not been trained to do this procedure. I trained at MD Anderson, and they still don't do it. Okay, the gynecologic oncologists at MD Anderson do not do HIPEC, and I wasn't really trained. I didn't learn how to do it. That's part of why I moved here to Tampa. If you ask me why I'm here in Tampa, is because I was interested in this procedure, and I came here to learn it from Tom. So many people haven't been trained how to do it. There's a whole litany of reasons why it's not more widely offered. Although it's typically, I will tell you, if you're interested in this, it's typically the oncologic general surgeons that are trained to do it. Most people will have like one person who does it. Okay, there's one person at Baylor who does it, although I heard he left recently. I know there was one person at Moffitt, and I think he left a couple months back to go somewhere to California, I think. Right? Okay, so there's not a large pool of surgeons who do this routinely. All right, other questions?
Any other questions? This is your last chance. I think that was so comprehensive that we don't have any questions.
Well,
But I want to take the time to thank you. Everybody give a virtual applause. They're muted. Yay.
thank you guys.
Dr.
Thank you for
Matt.
sticking with me. I know we ran way over, but hopefully this was helpful and you're able to follow all that. Lots of data, but I think it's a super interesting topic.
I do too. And thank you so much for your time. This will be available on our website, so you can send your ovarian patients to the website for this recording too.
Absolutely.
Okay.
Yeah. We have a whole big talk on ovarian.
Oh, okay. Well, thank you so much for your time. Thank you, everybody.
Awesome. Thank you, everyone. Take care. Hey, Susie.